Okay, great. Okay, orientation terms. Recall that when we orient ourselves to the body, when we look at structures that are any particular in the body, we always look at them from the front, anatomical position, so that our palms are facing forward, right? So this is the anatomical position. And from this position, this is superior, this is inferior. If you can, hit your mute button and then like start along with me. And so this would be superior, and this would be inferior, lateral, and then medial, and then lateral, medial, and lateral, medial, and lateral. All right, so medial and then lateral, anterior and then posterior, right? So anterior and posterior, yeah. And I wanted to point out one thing that's kind of interesting is that with some structures, there are anterior aspects that we may not think of as anterior, and one of those is the shoulder blade. So we have the shoulder blade, and the part that you can actually touch, that's the posterior surface, so called the dorsal surface of the shoulder blade. And on the underside, if you were to go through the chest and touch the front side of the scapula, that's the anterior portion of the scapula, which is where the subscapularis resides. So this is useful because we can use those orientation terms when describing where muscles are. For example, the subscapularis is on the anterior portion of the scapula. The infraspinatus is on the posterior portion of the scapula. The supraspinatus would be on the posterior and superior aspect of the scapula. Another place that you might consider in anterior and posterior are the joints, particularly the joints of the shoulder and then the joints of the hip. What's the joint of the hip called, by the way? Starts with the letter A. That's acetabulum. Acetabulum. Yeah. Okay. Acetabulum, yeah. And that is the femoroacetabular joint. That's the ball in the socket there, right? This is the deepest ball in the socket. This is the more shallow ball in the socket. So the acetabular joint, you can think of the acetabular joint as having a front surface, and that's where the femur, the ball of the femur, comes up and inserts on the anterior surface of the acetabulum. Likewise, the joint, the socket of the shoulder, that also has a name. What's that called? Starts with the letter G. It's called the glenoid. Yeah, exactly, the glenoid. So it's the glenohumeral and the femoroacetabular. So also there's an anterior portion to the glenoid, right? While we're on the subject of those areas, let's just remind ourselves that there's 3 projections coming off the scapula. One is the glenoid fossa, the other is the acromion, and the last is the coracoid process. Okay, so we did anterior, posterior. Also recall that one of the substitute terms for anterior is ventral. One of the substitute terms for posterior is dorsal. We also have anterior and posterior surfaces for the hands, although there's a term for the palm, which starts with the letter V. It's specific to the palm. What is that term?
Palmar?
Palmar, yes. Palmar starts with the P. Which one starts with a V, which is unique to the palm? So
with the P or V? I keep hearing a V.
With the V like Victor.
Oh, okay.
That.
Volar.
Volar. Oh,
everybody say volar. Volar, that's right. And they may throw that out at you. They may be like on the volar aspect of the hand, or whatever, and it can be a little bit confusing. Yeah, so volar, dorsal, right, or palmar, dorsal, or anterior, dorsal. This is anterior because this is the anatomical position. Okay, planes. Let's do the planes kind of quickly today. So this one is which one?
Horizontal, frontal.
Horizontal is this way.
Okay. Coronal.
Okay. Yeah, coronal. My hands are coming up and they're reaching the head, the coronal. right? Or the corona of the body, right? Also called the frontal plane. And what motions take place in the frontal plane? Which motions of the shoulder and the hip?
Abduction, deduction,
Good, those two are correct. How about for the neck?
flexion,
Great. What kind of flexion? Flexion looks like this. What I'm doing is this, right? So that's lateral flexion.
Lateral flexion.
Lateral flexion, right? So this is flexion, this is lateral flexion. Those are different movements, different planes. So for the frontal plane, that's lateral flexion. Also lateral flexion for the spine and lateral flexion for abduction, adduction at the leg, at the hip joint. Okay, and then this plane here,
Anterior,
um,
like, no.
I am moving anteriorly and posteriorly, but those aren't terms, those are more orientation terms, not so much plane or
Oh.
motion terms.
longitudinal,
That is correct. Longitudinal, also called the sagittal plane.
Yeah, sagittal plane.
Yeah, longitudinal or sagittal. So at the shoulder and at the hip, which motion is this?
flexion,
Right,
Flexion.
flexion and
extension,
extension. That's correct. And also it'd be flexion and extension through the spine, flexion and extension through the neck. Okay, and then the last plane we need to be concerned with is this way. And which plane is that?
horizontal,
The horizontal plane or the transverse plane. That's correct. And what's the name of this movement here at the shoulder?
Mm,
So look at the rotation of the humerus. Which way is the humerus rotating?
Anterior.
Not anterior. Anterior would be this way. Posterior is this way. This is rotation around an axis, and it's external rotation or lateral rotation.
Mm.
So you guys do this. This is the typical external internal rotation position that they want you to, they want you to know. But you have to know here, 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 and here in real life, and here. So let's start this way. So this is external rotation.
External.
Yeah, external rotation. Look at your humerus. Humerus is up here. Make sure that you're watching it rotate outward. External rotation. And this is internal rotation. Go back to neutral, internal rotation. Last time back to neutral and do internal rotation. Also lateral rotation, medial rotation. Say that to yourself or out loud. Lateral rotation
Lateral rotation.
and medial rotation. Great. Now let's put your hands down in anatomical position. Right. And with the thumbs facing out, we're going back. That's lateral rotation. External rotation. Let me hear you say that. Lateral rotation, external rotation.
Lateral rotation, external rotation.
Yeah, and then thumbs going inward toward the midline or continuing to the posterior would be internal rotation or medial rotation. Internal rotation or medial rotation. And then external rotation, lateral rotation, internal rotation, medial rotation. Okay. Arms up, let's just go to W for time's sake. And so external rotation looks like this. You guys had better be doing this on the chest. Internal rotation like that. Like external rotation, also called lateral rotation. Internal rotation this way. Arms up into a Y. External rotation like that. Internal rotation like this. External rotation, lateral rotation. Internal rotation, medial rotation. Same goes with the leg. I'll just quickly show you that, right? So this is internal rotation and then external rotation. Internal rotation, medial rotation, external rotation, lateral rotation. Okay. Let's do some joint movements. Let's do, let's see, I think we started with the shoulder last time. Let's do this circumduction at the neck and head, circumduction at the shoulder, right? Circumduction at the wrist. And we could also do that with the leg and hip. So circumduction at the hip. All right, flexion and extension. Flexion and extension. Flexion and extension. Flexion and extension. Flexion. Flexion. Extension. Flexion and extension. Flexion and extension. Flexors. Extensors. Flexion of the shoulder. Extension of the shoulder. Let's see what else. We already did lateral flexion, horizontal adduction, horizontal adduction, horizontal abduction. Oh shucks, I did this last time. I said horizontal when I was doing diagonal. Diagonal adduction, diagonal abduction, diagonal adduction, diagonal abduction. You guys please be saying these either out loud or under your breath. Yeah, don't be shy. Don't let me be the only performer. Now this is horizontal. This is diagonal. This is horizontal. Horizontal adduction, horizontal abduction, also called cross flexion. Cross flexion. All right. What else should we do? Supination, pronation. Supination and pronation. Shoulder blade movements, elevation and depression. One more time, elevation and depression. I find it easier to do protraction, retraction with hands up. So hands up, protraction, retraction. Shoulder blades together, retraction. Shoulder blades apart, sticking out into a full push up a plank. That's protraction, retraction, protraction. So let's go into joints now. So joints are classified in 3 different ways. Let's see, 3 different types of joints are classified. I'm sorry, joints can be classified in one of 3 ways. And I want you to keep this word in mind, classified, because part of the confusion around what we study is that we classify things in more than one way. So muscle cells, for example, are classified by morphology. That's like how the tissues are formed, and they're classified based on their function, like are they voluntary or involuntary, and then they're classified to be, I would say by type, like whether it's skeletal, cardiac, or smooth. And just knowing those 3 classifications are there can help to prevent a lot of confusion, because it's easy to mix up, for example, a cardiac type of muscle with an involuntary versus voluntary function of muscle versus a striated or non-striated morphology of a muscle. Okay, so with joints, there's also multiple systems that they classify by. Okay, one is the type of the way that the joints join. So it can be synarthrotic. I put these terms here: synarthrodial, synarthrotic, and synarthrosis, so that you realize that that it's really this first part of each word that gives away the nature of the joint. So synarthrosis or synarthrodial is 2 bones which have joined and are practically one. There's almost no movement in a synarthrosis joint, synarthrodial joint, right? And these are made up of fibrous tissue that join 2 bones, a joint joined by fibrous connective tissue. There's, generally speaking, like no cartilage, synovial type stuff between these joints. They're not meant to move, and they're meant to provide, if they provide any movement at all, it's marginal. They're also called fixed joints, right? And then there's amphiarthrotic, amphiarthrodial, amphiarthrosis joints. Those joints have cartilage between them, but they also have fibers, connective tissue fibers connecting them. And so they are slightly movable. And then diarthrotic, diarthrosis, diarthrodial, diarthur are types of joints that can move freely. And those are also known as synovial joints. And they're called synovial because the lining of the cartilage has synovial cells which secrete synovial fluid. Secrete happens inside the body, excrete happens from the inside to the outside of the body, right? So they secrete synovial fluid, and synovial fluid helps to cushion and lubricate the joint. And if we look at synarthrodial as immovable, amphiarthrodial as partially movable, and diarthrodial as freely movable, then we get an additional classification, which is by, I would say by the shape. I don't know what that terminology is called, but I would say the shape. So it's like, is it a suture or a primary or secondary? Is it a plane hinge? These are all shapes, right? Plane, hinge, pivot, condylar. Primary and secondary are also shapes, although they're less obvious names of shapes. Secondary is also called a symphysis type joint, symphysis, and then primary is called syndesmotic, and that may or may not be familiar to you as a type of joint shape. And then sutures, gomphosis, and syndesmosis, these all can be like confusing sounding, but they're really just referring to the way that the joint looks. Like a suture looks like a line that has been stitched with stitching across it. Those are the joints of the skull, for example. And we'll be looking at each of these tonight. Let me see if there's any other. Yeah, okay. All right, so just to review before we start getting into the details, synarthrotic has fibrous connective tissue joining two bones, and there's no movement between them. They're also called fibrous. Synarthrotic are also called fibrous. And amphiarthrodial, amphiarthrosis are also called cartilaginous or slightly movable, cartilaginous or slightly movable. Diarthrotic, diarthrodial, diarthrosis joints are also called synovial joints or freely movable. So you will hear fibrous, cartilaginous, or synovial. That's the same as synarthrotic, amphiarthrotic, diarthrotic, respectively. Okay, so sutures. Sutures are immovable. Coronal suture is the example that they list. So when you hear coronal, think crown, corona, think head, right? So the sutures in the skull are immovable. That's a fibrous or a synarthrotic joint. If you guys want to see any of these drawings, diagrams, anatomical pictures, you just let me know, okay? Otherwise, I'm going to go through them didactically, which means just verbally. Gomphosis, for example, dentoalveolar joint. So a gomphosis is examples of gomphosis joints are the teeth as they fit into the mandible or the maxilla, and those are held in there by tendons. And then yeah, teeth between the teeth and the mandible, and then the joint found between the first pair of ribs and the sternum. So rib 1, R1, and the sternum, which I think actually attaches to the manubrium. So there's the manubrium, then there's the sternum, and then there's the xiphoid. Is that correct? Is the middle piece called the sternum?
Yes.
Okay, thank you. I always forget if that's the whole thing or the one piece. So those are synarthrotic joints. Those are the synarthrotic joints. Where's the gomphoses refer specifically to the dentures or the teeth. Syndesmotic joints or syndesmoses are, for example, the interosseous membrane of the forearm and the leg. So I found a couple like different sources that say have different opinions. So some sources say that those are the syndesmotic joints are amphiarthrosis, and some say the syndesmotic joints are synarthrosis. So my opinion is that they are amphiarthrotic because unlike synarthrotic joints, those structures allow for slight movement. So if you were to take your forearm, let me know if you cannot see me. If you were to take your forearm and touch the ulna and the radius, something like that, or do it on the other side, however you want to, and you were to rotate, what you would feel is that right at the extreme of supination, there feels like there's a kind of like play in the joints between the ulna and the radius, right? There's free movement of the radius around the ulna, and then the movement kind of stops at the radius. And if you force it a little bit, you can feel like a stretch in between these two bones here, right? So that joint, this is considered a joint between the radius and the ulna, and it's joined by fibrous connective tissue called the interosseous membrane. It's between these two bones. And the same thing happens between the tibia and the fibula. So those membranes, those fibrous connective tissue connections allow for slight movement, but not a lot of movement. Their purpose is to be as supportive as to have the same kind of high integrity in structure as like the synarthrotic joints of the ribs, the synarthrotic joints of the sutures in the head, of the dentures, but to provide some movement. So I think probably so that there's like some shock absorption in the lower body. Let's look at the interosseous membranes just for a second. And of the information that you're preparing, this is like the lowest probability that you'll be asked. But if someone asks you, obviously you will need to know it. So between the tibia and the fibula, as well as between the radius and the ulna, there's this fibrous tendinous structure. And you can imagine that it would allow the fibula and the tibia, it would allow the fibula to move a little bit up and down, and even in and out. So if you were to grab your wrist, so you're grabbing your ulna and your radius, if you were to squeeze them, you should be able to feel there's a little bit of give between those bones, right? And that's a result of an amphiarthrotic, in my opinion, amphiarthrotic joint nature. Okay, it's really challenging for me to give you guys like complete information that provide you with some context of all this stuff, anatomy, physiology, kinesiology, patho, without giving you too much and without giving you information that you're not going to need. It's superfluous. Okay, so, okay, and then for the cartilaginous joints, think, let's go over these symphysis joints first. Symphysis. So symphysis joints are areas where there's thick cartilage. So that's the pubic symphysis, and then the joints between the vertebrae. So the intervertebral discs. Does everyone know what the pubic symphysis looks like? Yes, no?
No.
Not really. Okay. So if you look at the pubic symphysis, what you see right away is, well, and when they show the cartilage, what you see right away is that there is a thick piece of cartilage between the bones, right? And this piece of cartilage allows these two halves of the pelvis to actually rotate a little bit in opposite directions. And in childbirth, because of the hormone relaxin, which softens all the connective tissue in the body so that the joints can open, this pubic symphysis cartilage can actually stretch a little bit so that the left and the right aspects of the pelvis can drift away from each other, and that the birth, not the birth canal, I forget what this space is called, so that this space can open and the infant's head can pass, and then the whole body can pass through that space more easily. And then if you look at the joints, if you look at the vertebrae, I mean, you guys have seen this 100 times, that with the vertebrae, there are discs between, and we think of them sometimes as like jelly donuts, like things that have lots of fluid inside, which they do, but they're very, very tough. They have a very, very tough exterior made out of connective tissue. And over time they become compressed and then their integrity starts to break down. But they start out life as fibrous connective tissue with fluid on the inside. Okay. So those are symphysis joints. And if you go down a little bit further into the notes, you see under amphiarthrosis, you see symphysis joints. And then where is it listed down here? I don't see it down here. That's okay. All right, symphysis joints. So that's the pubic symphysis and the intervertebral joints. Discs. Hopefully you guys know that it's intervertebral joints, intervertebral discs. All right, and then the syndesmotic joints, right, which we just covered a minute ago. Okay, the diarthrosis or diarthrotic joints. These guys are the joints that we think of as the joints proper. They're the joint. These are the ones that allow the most movement in the body. These are synovial joints, so they have cells in the cartilage that secrete synovial fluid. So diarthrotic is the same as synovial, which is the same as freely movable. So if you guys can get those synonyms, those also known as, if you can get those down, it'll save you a lot of grief on the exam. Hopefully they ask you like several questions based on this stuff, because if you get some of the information in your mind, you can reproduce it from a couple different angles. So hopefully they'll ask you like, a dozen questions about these. May you be asked a dozen questions about the joints. So the synovial joints or the diarthrotic joints, they're the plane, hinge, pivot, condylar, saddle, and ball and socket. And in your March 2023 basics, there's a link here that you can click and it will open this chart. So let's go over the types now. So that is there a question? So this is the pivot joint, and the pivot joint is found. It's for sure found in one place of the body, and that's C1 and C2, which are actually be up here against the skull. C1 and C2. And they allow a turning around one axis. So this is one axis here. And in the elbow, this is one axis. See, the turning is happening around this axis, right? And then in like a ball and socket joint, this is one axis here. See, this turning is happening around this axis. And this is a second axis here. See, this turning is happening around this axis. And you could even say that there's one going this way, right? Which would be abduction, abduction. Oh, this is really clear. So this is one axis and then a second axis. Okay. So pivot joints. So pivot joints are found, one of them between the atlas and the axis. I did see this on one of the practice questions, and I didn't know this before the practice question. I'm in my field what's called a bonehead. So I was surprised that I didn't know this. But the atlas and the axis, they're the top two bones of the spine. They interact with the skull. They interact with each other. The top bone, the atlas, just like the Titan who was cursed to hold up the earth, or maybe he was cursed to hold up the sky. I don't remember. Anyway, so Atlas is the top bone, C1, which holds up the skull, and then the axis, C2, below it provides an axis. It provides a way for the atlas and the skull to turn. Think of the atlas and the skull as like one piece functionally. The skull moves and the atlas always moves with it. And the atlas and the skull turn around the axis. So that is pivot joint. Another pivot joint takes place in the elbow the proximal part of the elbow. Remember, proximal and distal. Hopefully all you guys can see me. I don't have my camera on tonight, my like review camera, so I can see. But the radius joint fits into this annular ligament up here and allows the radius to spin, allows the radius to turn. And it turns, here it turns like this, inside like this, inside the annular ligament. And then at the other end, the radius is going like this in an arc, right? So that's another pivot joint. Before we go over the other types of joints, I just want to show you guys this video, which I know it may seem, hopefully it doesn't seem like kind of lame to you that I'm like giving you other people's videos to watch. I really do think it's helpful to get more than like one perspective. Let's put this, I guess I'll just put it. Down here. Right. So if you go to classifications of joints, this is that thing that I sent you guys earlier today. I just thought that it was a really like exact, thorough, effective summary of the different kinds of joints. Notice they use the term fibrous, cartilaginous, and synovial. And Stephanie, what kind of joint is a synovial joint? Is that diarthrotic, amphiarthrotic, or synarthrotic? Synovial joints secrete synovial fluid, so that implies what? More movement or less movement?
More movement.
So would that be di, syn, or amphi?
Die.
Correct. Cartilaginous joints, Dora, no one will be spared. What do you think? Amphi or synarthrotic?
Synarthrotic, I believe.
Okay, so fibrous is connective tissue fiber joining two bones with likely no cartilage in between. And then cartilaginous would be connective tissue joining two bones with some cartilage in between. So do you think, which one do you think would have more movement, fibrous or cartilaginous?
Fibrous.
Okay, so it's actually the other way around.
Oh.
So fibrous has little to no movement. So that's syndesmotic. Synarthrotic, not syndesmotic, synarthrotic. Syndesmosis is a type of fibrous joint. And then cartilaginous would be somewhat movable. Okay, so that's that reference, which I thought was good. And here's a video which you should watch. Okay, let's go to the first chapter. Synovial joints. There's 6 types of synovial joints. That's like the plane joint, the ball and socket, the hinge joint, right? All those. And then, oh, here we go. So this is the one, this is the pivot joint I was talking about. So the pivot joint and rotation along one axis. This is the axis right there. See, I like how they draw it. It makes it really clear. You want to quickly get what an axis is. So here's the radius and here's the ulna. Here's the radius and the ulna. And right here, there's going to be a ligament. There's a ligament, annular ligament. And the radius turns inside of it. You see how the bone doesn't move medially or laterally. It turns around this axis, right? Down here, it moves medially and laterally. So yeah, see that?
Mm-hmm.
Okay, cool. And the rest of this video is like really useful. It's a very like quick, effective way to understand, oh, there's flexion, there's abduction, adduction, and then there's rotation around an axis and circumduction. So that must be like a ball and socket type joint. Okay, so now let's take a look at the hinge joints. So we find hinge joints in the elbow and in the knee. The hinge joints are the ones, oh, and in the ankle, between the tibia and the talus. The hinge joints are the ones mainly where we need to do flexion and extension. So elbow flexion and extension, right? Knee flexion and extension, and then dorsiflexion and plantar flexion at the ankle, dorsiflexion and plantar flexion at the ankle. There's like many types of joints in the ankle and foot, and the foot is made up of ankle and foot are made up of hind foot, the midfoot, and the forefoot. So there are more than one type of joint down there, but when we speak of the ankle, for the most part, we're talking about a hinge joint that allows for plantar flexion and dorsiflexion. Hinge joint. One thing I like about this video that they show in, for example, a hinge joint is that the hinge joint prevents certain kinds of movements. Yeah, so the hinge joint prevents.
It allows movement only on one axis. Its structure prevents rotation this way or this way.
See that?
The head of the...
It's kind of cool, right?
Mm-hmm.
Its structure prevents rotation this way or this way.
Yeah, so they cannot rotate around a central axis. It also cannot abduct or adduct. And then I'm going to let him explain saddle joints, which are of the most confusing. Let's just do that now.
The saddle joint. The saddle joint is similar to the ellipsoid, but the rotation is limited mostly because of the bone structure. The structure of the saddle is very interesting. Both bones have a concave and convex surface. Convex means the surface sticks out like a hill.
That might be that's a practice question I've seen in the AMTA. Which bone has both concave and convex surfaces?
Concave means the surface curves in, like a hole, or cave. The concave plane of one fits on the convex plane of the other.
Concave plane of one. So this is concave on the lower bone right here. That's a cave. And this is a convex on the upper bone. And this is concave on the upper bone and convex on the lower bone. Is that unclear to anybody?
No.
Okay.
It's like a 3D yin-yang, or a cowboy on a horse. The saddle makes the bottom piece, and the cowboy's legs make the top piece. The legs of the top piece, which wrap around the body of the bottom piece, allow a rotation this way. The body of the top piece can glide inside the legs of the bottom piece. So this unique structure allows the joint to flex, extend, abduct, adduct, circumduct, and very slightly rotate.
That's the thumb
An example
joint.
of the saddle joint on the body is the carpometacarpal joint of the thumb. Let's see that baby in action.
Sigh. Yeah, so anyway. So they will ask you stuff like that. Which bone has both convex and concave aspects on its surface or on its articulating surface? And the answer would be the saddle joint. Okay, let's keep looking at, let's keep going with these. So we did a hinge, we did saddle. Let's move on to condyloid, which is also an ellipsoidal, condyloid or ellipsoidal joint. So of the types of joints remaining, we have a few which are ball and socket, right? So the proper ball and socket is the hip joint, which is a deep socket the ball fits into. And then the shoulder joint, the glenohumeral joint, is a shallow socket with a big ball on top. So the glenohumeral is kind of like a scoop of ice cream, like a big scoop of ice cream on top of a ice cream cone. And this would be kind of like a stingy scoop of ice cream on a big ice cream cone, you know, like those big waffle cones that you get at the like bougie places like Cold Stone. They have these big funnel containers. I never understood what the purpose of those is. They're so big you have to eat the scoop with a spoon. So anyway, the ellipsoidal joint is also a ball and socket, but it's really shallow. It's really shallow. And the ellipsoidal joint can be found between the radius ulna and the carpals, so in the wrist, as well as the base of the index finger. So that's the metacarpal phalangeal joint, the carpals of the wrist, and in the elbow and the wrist joints. So if we look at the wrist joint, you can see that overall there's a very shallow ball and socket or an ellipse shape. So if we consider the ulna and the radius to be one bone, this is like a socket, like an elliptoid shaped socket. And this is like these bones, these carpals all together are like a ball, an ellipse shaped ball. So a ball is round like a sphere, an ellipse is more oblong, like an oval, right? So these are shaped like an oval on top, and this is shaped like a oval shaped socket, ellipse shaped socket. Ellipse or condyloid. I'll see the word condyloid used predominantly. So when you see condyloid, you have to think about the shape of the joint. You have to think about where it is and the shape of the joint. Also the base of the index finger. So so if we look at here's the thumb, here's the index, middle, ring, and pinky. And if you look at the base of the index finger, there's also an ellipsoid joint here, right? But if I'm not mistaken, the joints of the fingers, like all the joints of the fingers themselves, are all ellipsoidal joints. See? Doesn't that look like an ellipse?
Yes.
Yeah.
Yeah, so this would be the base, like this would be like what we think of as the knuckles, the striking part. And then I think these would be ellipsoids, but I'm not sure. But yeah, okay. So ellipsoid, that's when it says two axes that permit up and down and side to side motions for the wrist, what they mean is it allows flexion and extension, and it allows ulnar and radial deviation, If it were a saddle joint, for example, or a deeper ball and socket, it also would allow for like a sliding action, not a ball and socket. If it were a saddle joint, it would allow for like a sliding action. This socket also allows for circumduction. I don't know why that's not listed here, but I mean, I'm circumducting right now, so clearly it does that. All right, gliding joints. This one was a little confusing for me at first, but you just have to remember that the vertebrae are gliding joints. Also, there's the joint between the forearm and the wrist. So the joint we just looked at, which is ellipsoid, is considered to have gliding properties, gliding movement properties. And the ankle joint, which we looked at earlier and said was a hinge joint, is also considered to be a gliding joint. So joints can be more than one type, especially if it's like a shallow ellipsoid type joint. It could be shallow enough to operate as a plane, or if the plane has a little bit of a curve on it, then it could be curved enough to be an ellipsoid. And these are interesting. I doubt you'll be tested on this, but basically all the joints between the ribs and the vertebrae. So where the ribs join the spine, where the ribs join the backbone, those are all gliding joints. So gliding joints allow for quite a lot of movement. They allow for a lot of movement, and they allow for movement in a unique way. So if I take my hand, can everybody see my hand and wrist?
Yes.
If I take my hand and I do what's called translation, you can see that I can actually translate it forward and back against the wrist, against the forearm bones, and I can translate it left and right a little bit. And you can do this with your own. Just go straight left and right, and go anterior, go like dorsal and volar, and you can feel there's some play in there. That's called the drawer test in some parts of the body. Like in the knee, they call that the drawer test. And then the joints of the the vertebrae, the joints between the vertebrae, also because the vertebrae are flat, like checkers or like hockey pucks or discs, those joints allow the vertebrae great amount of movement. They actually can move forward a little bit. Sometimes we see them move forward and get stuck in people who hyperextend their spine a lot. Cheerleading, powerlifting, and gymnastics. And I also see it in dancers, ballet dancers. Sometimes it'll move forward a little bit. And then it can move forward and back, side to side, and it can twist. So the plane joint or the gliding joint actually allows for quite a lot of movement, 2 or more round or flat bones to move freely together, gliding in any direction, right? So that's interesting because that means that the ribs where they meet the spine have a lot more movement back there than we think. Like ribs can come out of place back there all the time, the same way that like, you get a bone in your wrist out of place and you traction your wrist, or you traction your fingers, or you move and it clicks and goes back into place. Same thing happens with the ribs in the back, except they don't go back into place quite so easily because of where they're located. So by virtue of the pressure and the traction on tissues that we do back there using our hands, we can actually put those bones back in place after relieving spasm and loosening things up, flushing fluids out and decreasing pressure in the area if they're swelling. Those rib heads can actually move back into place. Body work is cool. Okay, so let me just drill you guys a little bit. Oh, ball and socket, I think I mentioned. Ball and socket allows movement in all directions, and it's the hip and the shoulder. So Vincent.
Yes.
Which joint is deeper and which joint is more shallow? The shoulder joint or the hip joint?
The hip joint is deeper and the shoulders is shallower.
That's right. And what's the difference between the ellipsoid type joint and the ball and socket type joint?
One looks like an ice cream cone. The other one looks like well, they both look like ice cream cones. One looks like a scoop, a smaller scoop, and the other one's a bigger scoop.
That's the difference between the hip joint, which is the smaller scoop and the bigger cone, and the shoulder joint, which is the bigger scoop in the smaller cone.
Okay.
And an ellipsoid joint is less like a ball and more like a pancake or a football or an ellipse.
Oval. Okay.
An oval, yeah. An oval, yeah. Stephanie.
Yeah.
Name the 2 pivot joints in the body.
The 2 pivot joints
Uh-huh.
and the elbow.
They allow rotation around our axis. Yeah, which part of the elbow? The ulna or the radius?
The ulna.
Pivot.
No, the radius.
The radius, there you go. And what kind of joint is the ulna? Allows only for flexion and extension, like a door opening and closing.
Saddle.
No saddle, the only saddle joint's in the thumb. Yeah, that is a hinge joint.
A hinge joint.
Yeah, where's the other pivot joint? It's in the neck, where the neck meets the skull. What's that joint called?
Oh yeah, the pivot joint. Rotation. The axis.
Yes, the full name, please.
Atlanto-occipital joint.
There you go. Atlanto-axial. Oh, I put atlanto-occipital. It's not atlanto-occipital. This is like nerd freak out time. Atlanto-axial. Yeah, atlanto-axial pivot joint, not atlanto-occipital. No.
Some studying to do.
What's that?
I said I've got some studying to do.
Yeah, join the club. You and me both, apparently. Okay.
And me.
We're not forgetting about you. Dora. So hinge joints. So you just heard us say that the elbow is a hinge joint.
Mhm.
Can you name the 2 other hinge joints in the body?
Mm,
So these are joints
hip.
that only allow for movement in one plane, flexion and then extension. That's considered one movement.
Oh, and like the knee,
The knee, very good.
and the ankle, I believe.
The ankle, yes, yes. And the ankle is also considered not to do another kind of movement.
Gliding.
Gliding, that's right, gliding joints. Where are the other gliding joints in the body?
I guess your wrist might be.
The wrist may be a gliding joint. Yeah, can be considered to be a gliding type joint. But there's two other areas which are definitely gliding joints, which you're probably going to be tested on.
I'm not sure.
Okay, it's the bones in the body which have flat surfaces that contact each other. In this case, they're shaped, they
Like
have a round.
pelvis.
Higher than the pelvis. Higher than the pelvis. I know the joint you're thinking of, that's not bad thinking, but I think those are amphiarthrotic joints.
Oh,
And the gliding joint is a diarthrotic joint. So gliding joints are found between the bones that are shaped like discs.
oh, okay. I see. It's the our back. What is it?
Yeah, take your time.
Our spinal cord, our spine.
Not the spinal cord.
Yes, just
The spine.
I'm sorry. It's like at the tip of my tongue, but I can't.
Yes, I know. Yes, your brain literally is sorting through all the information and like trying to sort it, and it's organizing it more clearly right now. So congratulations, we are watching you learn. It's awesome, truly. And tonight, when you go to sleep, as long as you get enough sleep, your brain is going to actually do this sorting and associating tonight, and tomorrow you'll know it more exactly. And if you wake up tomorrow and you look at like gliding joints, first thing when you wake up, it'll be really powerful.
I find it like these words that we talk about I find myself like thinking about them throughout the days or day or night.
Yes. Yes. Welcome to the profession. Excellent. And then remember, it's just interesting that the ribs where they attach to the vertebrae are also gliding joints. Okay, and then the condyloid joints, where do we find those? Vincent?
The wrist, the elbow.
Yes, the wrist is the elbow. Yeah, I guess the elbow is, but they definitely would ask you about the wrist. And then something like the base of the index finger. Okay, I'm going to clarify. This is the thing that drives me crazy, is like, how much detail do I give you guys? Do I need to clarify every single the joint structure of every single finger? Yeah, maybe. Okay, let's take a break. So let's go over some pathology questions. If a person has uneasy feelings that are connected with sympathetic arousal, which psychological state are they experiencing? Alzheimer's, depression, schizophrenia, or anxiety? Uneasy feelings connected with sympathetic
Anxiety.
arousal. That's right. Which one is sympathetic? Fight or flight, or rest and digest?
Fight or
Flight. And parasympathetic, like a parachute, like floating gently to safety, is rest and digest. Yes. Did we have this one before?
No.
I don't think so.
Good. Yeah, please let me know if I start doing questions and it seems like we've had them before. Okay, there's 4 choices here. I only have 2 listed and then the answer. A client comes to a massage therapist with reports of chronic pain. The client states the pain began in his low back 5 years ago after falling off a ladder. He has experienced low back pain ever since and now feels pain in the cervical and thoracic spine as well. The therapist notes the patient is extremely sensitive to touch and feels pain with nearly any touch to the lumbar or thoracic region. What must the therapist consider? The client may have kidney stones. The client may have an acute exacerbation of chronic low back pain. The client may be having a heart attack, or the client may have central sensitization and would benefit from a multidisciplinary approach.
See the B or D.
It's D. It's D. Yeah. B would be a smart guess, but this is an example of a question that depends on you knowing that the word central refers to central nervous system, right? So how stimulus, how information is collected and responded to, and interpretations of things like pain, and then sensitization. What does it mean? What does sensitization mean?
Sensitive, maybe?
Yes, it's when you become more sensitive. And when you become desensitized, what does that mean?
You lost your sense.
That's right.
sensitivity.
Exactly. You lose the sense or you become less sensitive to something. Yeah. So central nervous system sensitization is a central nervous system that's highly, highly sensitive. Does that sound like like this person? The patient is extremely sensitive to touch, and it feels pain with nearly any touch to the lumbar or thoracic region. Now, this next part would benefit from a multidisciplinary approach. How are you supposed to discern that from the description of the patient?
Just by knowledge of it, since he's sensitive, you probably want to use hot rocks or something warm or something cold on it, compression.
Yes, maybe, but from what's written here, you can't really tell that.
Yeah.
So, but still, the aspect of it being the central nervous system and it being sensitized, highly sensitive, and the description of it, person being extremely sensitive, makes D a better choice than B. All right, so hopefully I can give you guys a few recommendations on how to suss out the questions based on that kind of thing. Yeah, go ahead.
Well, the AMTA, we actually done this in like our classroom at school. So I know what you're doing. I'm taking screenshots, but I don't know if at any point we can go to the website and actually do a test.
Oh, you want to do the FSMTB test tonight?
No. And this is the AMT app, right?
Yeah,
like
yeah.
Well, the website, you can actually go in through the website and do a live test.
You want to try that tonight?
Oh no, well, I mean, I don't want to take up time, but like for next time,
Well,
just a suggestion.
well, do you guys want to try that tonight, or do you want to continue with this?
It's up to y'all.
I like this. I don't want to fail.
Oh no, it's
Well, I mean, look, if you Dora, if you want to try taking the live test, I mean, it's totally fine for me to look into it.
Yeah.
This is not like the login that you did for like the actual exam.
No,
this
that's this is the AMTA app, and the login was for the FSMTB.
Right. So this is just like us to like practice, and I like actually reading the explanation.
Yeah. But you're interested in doing the FSMTB?
No, not at all.
You want to do the AMTA, a test on the AMTA website?
Yeah, because
during the class?
It gives us the explanation, and it says benefits from multidisciplinary approach. So I'm like, what does that mean?
Well, the explanation, I say the explanation is here in a lot of the questions, but I just didn't record it for this one.
Right.
Because I felt like this was a test taking question solution rather than relying so much on your knowledge of like what a multidisciplinary approach would be, because it wasn't part of the question. But are you asking what is your concern? Is it that there's no explanation? You would have liked to have had an explanation for this question, or is it that these are practice questions and you want to do a live mock test?
A little
Or
bit
is
of
it
both.
both? A little bit of both. Okay. Okay. So
Because I like
let's-
to see. My thing is, I don't know a lot of the words.
Yeah.
So when I explanation, I'd be like, oh, okay. So that's what that word means. You know, like I just
you
like to
mean like Stephanie was asking, I think, about word breakdowns and medical terminology.
yeah. What I meant
Yeah.
with that was, like, you know how they say it's like arthritis, like itis, you know, when you see that, you know, it's like inflammation.
Yes.
That I know. But there were some words on the actual exam that I was trying to break down, and I'm like, I don't even know. Like I was trying to break down the words,
Uh-huh.
but I didn't know what some of them were.
Yeah. Okay. Maybe it was you asking me about the word breakdowns. You know, we definitely can go through the words, and you can please ask at any time if it seems like I'm assuming you know what a word means and you actually don't. Just chime in at any time. And I do recommend that you watch the medical terminology video that I made, and there's a presentation, a slides presentation in the MBLEx folder. It's in there under medical terminology right here. So as far as the MBLEx mock exam, I didn't know that there was one on the AMTA website. What I see is that there's a study guide, and the study guide that I'm aware of is the app, and that's what I'm using here.
Yeah.
Is there an exam on the page on the website, or
It's
is it
just
the app?
It's just like the app, but like through the computer.
The app through the computer. Okay. Well,
I could take a look at it later and then kind of like send you the link. We do it in class.
okay.
Well, I don't want
Okay.
to take time.
Yeah. Why don't you send me a copy of where that specific exam is?
Okay.
I'll be using some of the FSMTD questions, like as many of them as I can answer and then screenshot in our classes very soon. And these questions are always worth asking, because there's so many resources and it's confusing, and all of the resources out there will try, in my opinion, wrongly, to convince you that the best way to prepare for the exam is to take as many questions, to study as many questions as possible, to see as many questions as possible.
Mm-hmm.
But in my opinion, that's not the best way to learn to prepare. The best way to prepare is to actually learn anatomy, physiology, kinesiology, and to actually learn the concepts, right?
Right.
That's what I think. Okay, let's move on. But again, you have to study, the rest of the week. You know, just showing up to the class is not going to be enough practice for you. You have to practice on your own. And I don't want to be mean to you guys by any stretch, but I do think that you guys should know these kinesiology terms and joint movements, like the stuff we went over in the beginning. You guys, I think, should know those better by now. And the stuff relating to action potentials and muscle excitation, I think you also should know that better, although we did just introduce that recently. But I strongly suggest that you guys make that part of your daily routine. Okay. And there's too much, there's too much, like I'm trying to play the averages that over like, if we split everything up into, like, let's say if we split all the material up into thirds and we cycle through 1/3, we do 1/3 on every class. I'm trying to play the average that'll give you guys enough exposure to learn 100% as we cycle through things, because we can't do 100% every class.
Right.
So it's just like, I'm guiding you and reminding you and clarifying, but you guys have to actually do the practice and the drilling. All right. Okay. All right, here we go. So when a part of a person's stomach protrudes through the diaphragm, they have a umbilical hernia, hemorrhoid, inguinal hernia, or hiatal hernia?
Hiatal.
Okay, the answer is hiatal. If anybody wants clarification, you let me know, all right? Fill in the blank. Under the direction of a physician, a massage therapist sees a client with a diagnosis of what? Because this client bruises so easily, it is essential that the therapist uses extremely light pressure. So which one of these bruises easily? Pneumonia, anemia, hemophilia, or sciatica?
Hemophilia. I believe.
And the answer that they give is hemophilia. Yeah. Blood clotting disorder. Anemia is low red blood cell or low hemoglobin. Which term best describes inflammation of a bursa? Is that tendonitis, bursitis, tenosynovitis, or cystitis?
Bursitis.
Bursitis.
Yep, bursitis. Which of the following is an example of a respiratory infection? Is that anemia, asthma, pneumonia, or phlebitis?
Pneumonia.
Pneumonia, yeah. If an individual is diagnosed with cirrhosis, which part of the body is affected? Esophagus, stomach, colon, or liver?
Liver.
Yep.
Which one? Oh, liver.
The liver, yeah. Where is it?
Any clarification needed for that?
No.
Percussive techniques are an excellent way to stimulate muscle tone. When performing percussion over the lateral aspect of the lower ribs, which of the following structures might be damaged? The liver, the carotid artery, the aorta, or the kidney?
The liver.
That would be the kidney.
What?
So let's look at that. Lateral aspect of the lower ribs. Lateral aspect of the lower ribs. So aggressive percussion to the client's lateral lower ribs risks damage to the kidney. Percussion is sometimes an appropriate technique to use in this area, but should be performed lightly and with great caution. The liver and aorta could be damaged during abdominal massage, and the carotid artery could be damaged during massage inferior to the ear. Okay, so neither of these areas is likely to benefit from tapotment. What does that statement mean relative to the abdomen, Stephanie? Neither of these areas is likely to benefit from tapotment. Relative to the abdomen.
They're not nowhere near there.
It's not an area where you would do tapotment.
Okay.
So tapotment is not on the abdomen, but on the back is what it's saying.
You will do the tapotment on the back. You won't do it on.
That's
You
right.
don't do it on by where the liver is.
Yeah, well, I don't think that you would do tapotment on the anterior surface of the body at all.
Yeah, but that's how they are. They don't want the right question. They want the best. They don't want the right answer. They want the best answer. But if they would have put like anterior,
Or
lateral,
posterior lateral aspect of the ribs, yeah, then it would be clear.
yeah, they just put lateral.
Lateral aspect of the lower ribs, that's right. And they assume that you know what?
Where all this stuff is at.
They assume that you know where the percussive technique is done and not done.
Yeah.
Yeah. Fill in the blank. Blank is a condition that causes pain in the bottom of the foot and heel, especially upon first weight bearing after getting up from sleep.
Plantar.
Plantar fasciitis, that's right. And the other choices are bunion, Achilles tendonitis, and sciatica. Fill in the blank. A massage therapist is employed by a doctor. Whenever the doctor assigns the therapist a new client, the two colleagues schedule a meeting to discuss the client's health history in advance of massage. In the course of this discussion, the doctor tells the therapist about the patient's what, which is the expected outcome of the patient's illness. Sorry, guys, is it too loud right now?
No.
Okay, good. In the course of the discussion, the doctor tells the therapist about the patient's what, which is the expected outcome of the patient's illness. Symptoms, diagnosis, prognosis, or syndrome?
Symptoms.
Prognosis.
Vincent, what do you think?
Prognosis.
Yes. Can you tell us why?
Prognosis is before this, the, what is it, the subject before the diagnosis, and it's after this, before the symptoms, after the symptoms have been introduced. I think
That
that's how you say it.
that's right. After the diagnosis, it's after both diagnosis and symptoms, right? You see the symptoms, collect the symptoms, you diagnose the problem, excuse me, and then from the diagnosis, you have, in combination with the patient's health history, you have the prognosis. So, Dora, you were asking about word breakdowns, right?
No, that was me.
No, that was
Stephanie?
Stephanie. Yeah,
Okay,
but
so
I'm with her.
Okay, so prognosis, gnosis means knowing, and pro means before. So prognosis, knowing before, literally means prediction. So you're predicting what's going to happen with the patient's health, the expected outcome, before it happens.
Yeah.
Like, this will resolve in 6 weeks, or this will resolve in a year, or whatever, right? That's ahead of time. Diagnosis means across, knowing across, kind of like if you imagine a field of information or lots of information laid out on the table, you're going straight across all the superfluous extra information to the one piece that is the diagnosis, the one piece that is the cause. And then symptoms are what the patient experiences. So that's subjective. And then a syndrome is a collection of symptoms, just so we have it all. Anyway. Okay, a 15-year-old basketball athlete complains of ongoing pain over the front aspect of his knee. Which condition would be most likely? Muscular dystrophy, lupus erythematosus, bursitis, or Osgood-Schlatters disease? Front aspect of his knee.
Osgood-Schlatters disease.
Well, I would say either bursitis or Osgood-Schlatters disease, right? Because bursitis there's like 4 or 5 bursa in the knee. So what I want to know, Stephanie, is how do you know that it's Osgood-Schlatters in this case? By reading about the patient.
That was actually my instructor at American Institute has this issue, and it started when around the young kid's age, and she just told us that she gave us background on it. So
by the age of the patient?
Yeah, because
Yes.
it started around that time when they're like doing sports and stuff, and she did a lot of sports, and that's when her Osgood disease started.
Yes, and Osgood-Schlatters disease is when the bones grow really quickly and it pulls the tendon away from the bone, and a painful bump, like a bone spur, starts with fluid and then forms a spur, starts to develop. So yes, Osgood-Schlatters disease. Okay, if an individual has, and it's the age of the patient. If an individual has a blood clot within his blood vessel, what does he have? Varicose veins, thrombus, spider veins, or arrhythmia?
Thrombus.
Thrombus, yeah. Thrombus. Fill in the blank. Blank is a condition in which there is an excess of interstitial fluid resulting in tissue swelling. Is that dehydration, edema, atrophy, or hypertension?
Atrophy.
Try again.
Atrophy.
Okay, try an answer other than atrophy. It's not atrophy.
Yeah, I think it's edema.
Edema, yeah. It is edema. So what does interstitial mean?
In between.
Yeah, that's right. Very good. It means fluid like in between the cells, or fluid in between the tissues.
Right.
Edema, yeah. An older client is scheduled for a session with a massage therapist. At the beginning of the session, the client notes she's feeling lightheaded and having difficulty breathing. Her blood pressure is 170/110. She has never been treated for high blood pressure. What action should the therapist take next? Continue the treatment while frequently asking the client how she's feeling, not continue the treatment, and have the client call for her doctor while in the office, not continue the treatment and send the client home. Not continue the treatment and have the client, I'm sorry, I didn't record all the possible answers, but it's not continue with treatment and have the client call her doctor. So client's blood pressure reading and other symptoms are consistent with severe hypertension. What is hypertension?
High blood pressure?
Exactly. Because she has not been treated for high blood pressure, this condition is uncontrolled. This is an extremely dangerous condition and a contraindication for massage. It is imperative that the client contact her doctor immediately. By the way, what kind of contraindication is high blood pressure? Is it general or is it specific?
Specific.
So it's actually general because it's systemic, like body-wide. Specific would be something like if someone has like a DVT, deep vein thrombosis, and they have pain in the leg in a specific place, maybe with a history of DVT or recent airline travel, or if someone has like a red area that's right on top of or right around a vein, such as I forget what that's called, but it's inflammation of the blood vessels, then that would be specific.
We'll say like a local contradiction.
Yeah, a local
Something you can see.
Yeah, it's something that's in a smaller area.
Okay.
Or you just avoid like that area, like you can massage the leg, but just avoid the area, like the bruise.
It depends. It depends on what it is. Like, if it's something like let's say it's something that could have, it could be dangerous, then you have to refer the client to a hospital. So things that are dangerous that you can't mess around with at all are signs of possible concussion, which may have some maybe accompanied by bleeding, intracranial bleeding or brain bleeding. So that often looks like, after a knock on the head or some kind of fast movement of the head, like sometimes people get them from spinning really quickly. Like, I don't know if you've ever seen, okay, if somebody has a fall or if they're in a car accident, but they don't hit their head, sometimes the head whips or it moves quickly enough that it actually hits the brain inside the skull, right? So they didn't hit their head, but they had some kind of traumatic thing happen, right? Hockey, soccer, car accidents, hit by a bike, etc., martial arts. And it's accompanied by like no memory of what happened specifically. There can be headache, dizziness, some of their systemic regulation, like their ability to regulate their temperature or sweating maybe off, things like that. When in doubt, refer it out. When in doubt, refer it out. But a lot of local stuff that they're going to ask you on the MBLEx is going to be stuff about like skin. It's going to be about eczema, ectopic dermatitis. They might throw a question in there about a local infection. So like if there's broken skin and it's swollen and red and inflamed, what do you do? And the answer is you avoid that area, right? So some things you just avoid the area, but some things you have to refer to a doctor like right away because there may be a more systemic threat. But for the most part, I think the answer is going to be avoid the area for the local stuff. Okay, so massage therapist begins seeing a client who has Parkinson's disease. This client takes regular medication for this condition. Given this, what is a potential side effect of massage? I'm sorry, what is a potential effect of massage for this client? Parkinson's disease, takes regular medication for this condition. So they want to know if you understand the effects of the medication for Parkinson's disease. So what do you guys think is a potential effect of massage for someone who takes these kinds of medications? Bruising, dizziness, inability to relax, or excessive drowsiness?
Inability to relax.
I think it's the drowsiness.
I thought it was bruising.
Okay. Okay, so bruising would probably be an effect of blood thinners,
Yes.
like warfarin or Coumadin. And for Parkinson's disease, I think what they use are
They have a shake, right? They have a tremor.
they have Parkinson's is manifests as a tic or a tremor, but it's due to a lack of serotonin, I believe, or maybe a lack of dopamine, right? So those are the drugs those are the neurotransmitters that allow us to be calm or to relax. Those are endorphins. So if you start supplementing endorphins with a medication, putting endorphins in the body, it can result in drowsiness, not the inability to relax. That might be a stimulant. And then dizziness, not sure what would cause that, but this is a good question, a good explanation to read through. So it is excessive drowsiness. All right, dizziness is a potential side effect for clients taking a variety of medications. So many medications, including beta blockers and antihypertensives. Antihypertensives, those are taken for hypertension, which is high blood pressure. Did anybody not know hypertension was high blood pressure?
No.
And beta blockers are often used to correct heart rhythm defects like arrhythmias. Beta blockers. Bruising is especially relevant when working with patients on anticoagulants like blood thinners. Clients using central nervous system medications may have a hard time relaxing. So those are stimulants. So those would be some medications for things like ADHD. However, this is not a direct result of massage. Medications to correct the chemical imbalance of dopamine in the brain. For clients taking these,
Do with
yes,
the medication that they're taking, depending on. Okay.
yeah, it has to do with the type of medication that they're taking. So this requires that you know four different kinds of medications and their mechanisms on the body and some of the effects that massage could have on them. We will be going over different classes of medications more specifically. So this is something we haven't gone over, but you guys already have a lot of knowledge about that. A massage therapist applies pressure to a specific area of the upper right trapezius. When he does this, the client reports pain with this that radiates along her upper arm. What is the most likely direct origin of these symptoms? Pain along the upper arm. Is it a pinched nerve, a trigger point, hepatitis, or radiculopathy?
Trigger point.
Tricky question. Okay, let's see. The answer that they're looking for is a trigger point. And pinched nerve and radiculopathy are one and the same. While this condition can cause radiating pain along the arm, the symptoms would not be reproduced with compression of the upper trapezius. Yeah, so a pinched nerve or radiculopathy, those are the same. And those are caused by compression closer to the nerve root, so closer to the spine. So that might be a herniated disc, or it might be a compression between the vertebrae, or compression between the rib heads in the vertebrae, like a rib head being slightly out of place, or one of those gliding joints, the vertebrae being slightly subluxed. Blank can arise from the stimulation of receptors in the skin, muscles, joints, tendons, and or connective tissue. Blank can arise from the stimulation of receptors in the skin, muscles, joints, tendons, and or connective tissue. Is that somatic? Go ahead.
I'm sorry. I was going to say visceral.
Sorry about that.
All right. So is that you guys obviously don't think it's one of these three. So I'll just ask you, is that somatic or is that viscera?
Visceral.
Skin, muscles, joints, tendons, connective tissue. Does that sound like viscera?
It should be somatic, right?
Should be somatic. That's right. And why would the answer, Victor, not be muscle? Why is somatic a better choice than muscle?
Because there's stimulation. I'm sorry. Yeah, so stimulation means it's the sensory part.
Close, but not quite. It's because muscle is one part of all the somatic structures, and all these somatic structures are listed in the question. So somatic includes muscle. Somatic includes muscle, right? So this is the better choice because it includes B, includes muscle. Somatic pain. Somatic pain can arise from the stimulation of receptors in the skin, muscles, joints, tendons, or connective tissue. Muscle pain is just one example of somatic pain. Phantom pain is experienced in a limb or other body part that has been amputated. Visceral pain is pain of the internal organs or viscera. Internal organs or viscera. Fill in the blanks. A client with a heart murmur has a heart that has abnormal contractions, a heart that beats irregularly, a heart that receives decreased blood due to a blocked artery, or a faulty heart valve.
Faulty heart valve.
That is correct. Does anyone not understand this? Heart murmur is the result of a leaking heart valve.
No, I have one.
Oh, okay. All right.
That's why I get that one right when it comes up.
All right. Which of the following underlying structures could be injured during massage to the ulnar notch? The ulnar notch. Which structure? The brachial plexus, the carotid artery, the ulnar nerve, or the subclavian artery?
Brachial plexus?
Brachial plexus is in the neck and upper and like deltopectoral triangle area, so front of the chest.
The ulnar nerve then, because
It's got to be the ulnar nerve because the carotid artery is in the neck, subclavian artery is around the clavicle. Ulnar nerve. Looks like that's all that I have for you for pathology for these questions. I think I may have another set of patho questions in here. Pathology contraindications. Let's see what this one says. Oh yeah, this is oh yeah, there's a few more here. Okay. So okay, I've indicated the answer, but we can still go through it. So an athlete is running and suddenly steps on an unexpected rock and rolls her ankle, which results in immediate pain. What system does this predominantly activate? Predominantly, in bold letters, activate. Is it the sympathetic nervous system, parasympathetic nervous system, the enteric nervous system, or the central nervous system? So it's sympathetic because why, Dora?
I'm not sure, to be honest.
Okay. Okay. So when they word a question, try to look at the words in the question. So steps on an unexpected rock. So what does it feel like when you have an unexpected thing happening while running?
It's a sudden thing.
Sudden thing, which is
Sudden movement.
yeah, kind of shocking, right?
Mm-hmm.
Or scary or similar, right? So that's sympathetic nervous system, right? So sympathetic is fight or flight. Parasympathetic is rest, digest, attend, and befriend, like parachute. Enteric means what, Stephanie?
enteric.
Yeah, enteric.
Oh.
This is the third nervous system of the body, the third nervous system. It's the brain of the gut. So it's the wiring of the digestive system. It has its own timing, its own rhythm. That in part is why our stomach growls. We get ready to digest at the same times every day. And it's why we feel full, because we have a nervous system in there that tells us when our organs are distended and full of food. Enteric nervous system. And then the central nervous system, that's the central nervous system, right? Compared to the peripheral nervous system. By the way, Victor, the sympathetic and parasympathetic nervous systems, they're two branches of which part of the nervous system? Central or peripheral? It's also called the sympathetic branch and the parasympathetic branch. It's the peripheral nervous system.
Peripheral.
Yeah, peripheral. Yeah. Okay. A client informs you that he is taking omeprazole, brand name Prilosec. What type of health problem is he most likely to have? What type of,
Gastro.
that's right. And Prilosec or omeprazole is specifically for what symptom?
Stomach issues.
Yeah.
Yeah.
Gastritis or something.
Gastritis. GERD, gastroesophageal reflux, heartburn, reflux. Yeah. Okay, just one more. Fill in the blank. The anterior triangle of the neck is considered an endangerment site because it contains all of the following structures except for jugular vein, carotid artery, vagus nerve, or the brachiocephalic artery. Which one is not in the anterior triangle?
Brachiocephalic?
I believe so, yeah. Did we look at the anterior triangle yet?
No.
Oh, we didn't look at that? Okay. We should look at that next time. But yeah, all these structures here are in the are in the anterior triangle. Okay, guys. Good work today. As usual, if you have any feedback for me, or if you want to suggest like places where resources I might consider that you want me to consider bringing into class, just put it in the chat, put it in the group text, and I'll take a look at those. All right.
All right.
All right.
All right.
Try to look at some common medications for the next class. I will see if I can give you some specifics, ask you some specific stuff like I have been, or point you in the right direction for Thursday. Okay.
Okay.
All right.
All right. Have a great class. Have a great couple days.
Thank you.
Okay.
Good night.
You're welcome. Good night. Bye-bye.